Hey, everybody. Thanks for tuning in today. This episode is a little bit different than our standard episodes. It's a very time sensitive one. And if you are listening to this right now and the episode is still live, what it means is that you can still do something about this. It's not too late to take action. And we strongly encourage you to do so. So what's going on today is that the DEA, which is the Drug Enforcement Administration in the United States, is proposing some new rules about how to regulate telemedicine. And so in their proposal, they want to regulate Schedule II drugs in a very particular way. And this is going to affect ADHDers. So what they want to do is ensure that Schedule II medications that are prescribed via telemedicine, which is the case for many of us, the prescriber needs to be physically located in the same state as you, and practices that do partial telemedicine can only prescribe half of their Schedule II prescriptions via telemedicine. So Schedule II drugs, those are stimulants, so that's Adderall, Ritalin, ADHD drugs, and they're basically trying to put limits on the way in which those can be prescribed. So for every person who receives their monthly prescription of Ritalin, there needs to be someone else who gets prescribed in person by the same clinic. And so you can see some of the fallouts from that, which we're going to be discussing in the episode today. So like I said, if you're listening to this episode now, it means that it is not too late to take action. And we have links posted to this actual proposal, and the government is taking comments up until March 18th. And so you'll be able to hear us talk about the law and the issue and why you should care, why it matters in this episode. And hopefully that'll give you some ideas and you will feel inspired to comment, because if you live in the United States right now, the DEA works for you. This is your country. And your opinion matters, and you should feel empowered to voice that opinion and try to shape the future decisions around your needs and the needs of your community. So stay tuned for this special episode. Thanks for listening, and know that your voice matters and you can make a difference.
Welcome to It's Just ADHD. We're two curious ADHD coaches, and we're going deep on the how, the why, and the strategies to get through the difficult moments and how to make the best of life with ADHD. I'm John, and I've got an adult diagnosis of ADHD.
And I'm Tara, and I have a late in life ADHD diagnosis and an even later autism diagnosis. We're going to be diving headfirst into the messy and often complicated research around ADHD and autism. And we're bringing you along for the journey as we break it all down and make sense of everything.
Because sometimes it's just life.
And sometimes it's just ADHD. So before we begin, I just want to remind you that this podcast is for informational purposes only and should not be considered medical advice. It is not intended to replace professional medical care. We are not doctors. We don't claim to be. We are just a couple of nerds who find this information and this research really fascinating, and we want to discuss it, but please keep your medical decisions between you and your doctor and keep us out of it. All right, let's begin. So anyway, I've been trying to kind of grok what this law actually means, and especially like what it means for ADHDers, because they talk a lot about controlled substance, but you have to understand what controlled substance actually means. Like in the US, anything that's a controlled substance is something that you cannot walk in to a CVS and like buy over the counter, or not. I don't even know if over the counter is considered. It's anything that you can't buy off the shelf on CVS without talking to a pharmacist first. So like something like Sudafed 12-hour, for example, is restricted. Anyone can get it. You don't need a prescription for Sudafed, but they do put it behind the counter and they like scan your driver's license when you're purchasing it, because you can turn Sudafed into meth. And so the Ryan Haidt Act which was pre-COVID, required that you had to do at least one in-person medical evaluation of a patient before prescribing a controlled substance.
Well, real quick, a little background about the Ryan-Hay Act. It's that a healthcare provider must conduct an in-person medical evaluation before prescribing controlled substance. That's what you said. And online pharmacies must register with the DEA and comply with strict regulations, which is why there's like so many hoops to jump through. And the law limits the ability for telemedicine providers to prescribe controlled substances without the in-person visit. That's that once a year thing you have to do. And the act gave the DEA authority to create a special registration process for telemedicine to provide controlled substances without an in-person exam, but they failed to implement the process until its recent 2025 proposed rule, which I think is where we are now, right? Mm-hmm. This is like, now they're implementing it. The background on it though, what I'm finding is it was named Ryan-Hay after an 18-year-old who died from an overdose after obtaining prescription opioids online without a legitimate prescription. His death highlighted the dangers of unregulated online pharmacies, leading Congress to enact stricter rules. So that's unfortunate, but that feels like a really heavy hand. I mean, obviously nobody should get medication and die. The COVID-19 pandemic temporarily relaxed the in-person visit requirements, allowing telemedicine providers to prescribe controlled substances without, and it expired on December 31st, prompting the DEA to propose the new special regulation rule, which again is where we are. It's the foundation of federal telemedicine and online prescription regulations. And the DEA's recent proposal is the first major update in over a decade. And it's starting to seem like this can have huge repercussions for a lot of people who have been able to get their medication, even as hard as it's been to get, with all of the shortages, with all of the like hoops to jump through. This could make it a lot harder.
And so then during COVID, they did sort of a amendment on that where they were like, okay, we're expanding. You don't have to do all this like special registration, because that was what the Ryan-Hay Act stipulated, is that you had to have like a special registration that showed that you had special circumstances. But apparently they're saying in this article, in the more than 16 years since the Act's passage, the Ryan-Hay Act, the DEA failed to implement such a process to be able to have like a special registration. So they've never quite defined what special registration is. So anyway, COVID hit, and then they were like, well, we have to do telehealth for everybody's safety. And so they kind of dropped a lot of the requirements in Ryan-Hay. And so
I don't know if it was like because of the specific act, but he basically, like the law is that you have to meet your psychiatrist in person in order to continue prescribing, and it just felt like such an arbitrary jumping through hoop.
Yeah, and I'm unclear about all the details. I was trying to kind of grok through all the text here. Ironically, when you're on the like regulations.gov website, they have a little info bubble that says that they're legally required to explain it in plain text, like in layman's terms, for any of these things that they're trying to pass. And I think what I was reading was the plain text, and I was still like, I'm not totally following. So this stuff is like gnarly and pretty impervious. So what I'm saying could be, this is all the caveat, what I'm saying could be dead wrong here, but I suspect that there have always been special rules for Schedule II drugs, because my doctor makes me come in person once a year. And then I also have to meet with him like once a month to get, or I think maybe there's some rules like every 2 months, every 3 months or something, to continue to get Schedule II, which for folks that don't know, the schedule system is like their way of ranking, quote unquote, how bad a drug is or how scary a drug is. And it's not actually based on like, I don't know, it's kind of arbitrary. Like it's not entirely based on the riskiness or like the side effects or something. So Schedule 4 is like low control. So I would guess that like Sudafed 12-hour would be considered Schedule 4. And then they have Schedule 3. And then Schedule 2 is where ADHD meds fall. So you could call that the like barely legal band. And that's where they make you jump through all these rules. So basically during COVID, they had to roll it back to some extent, like create amendments that made it easier to prescribe medications via telehealth because we had to, we couldn't go in person.
Now, the one that continues to just like baffle me in frustrating ways are the way that ADHD medications are handled. Like people should not die, and we should protect people. That's definitely unfortunate. But that sounds like a failing of like at the system level, like how we actually manufacture and distribute, and even at the pharmacy level. And it puts the burden on the individual, so much on the individual to have to go through these hoops to get medication that is needed. These aren't party drugs, right?
And so that's the thing that you have to keep in mind, right? Is that when they are making these laws, they are talking about our meds in the same breath that they would talk about literally opioids. And so when they're putting these restrictions in place, for all intents and purposes, they're treating you the same way. And so, yes, some ADHD medications do have high abuse potential. So
just the idea of trying to take them for fun or how they can get
I can't imagine that.
Right. And yeah, it's hard for me to imagine because I take it, and I have actually like when I was taking Adderall and even Focalin, like there were days where I would I would forget and I would take two at once, and I would know I made a mistake, because it's like flying too close to the sun. Like I could barely talk. It's challenging. So certainly these medications have the potential to be abused, and it can be life-threatening in certain circumstances because they're so effective. They provide so much more benefit. They help so many millions of people daily. They provide so much benefit in order for us to be able to function, that the risk, like the level that they are being abused, which yes, they can be abused. People should not abuse them.
Well, it also feels heavy-handed to class them all together, right? Like Vyvanse is a very different risk level than Adderall. Same active ingredient, but Vyvanse cannot be snorted. And so why are those paired together? Why is Concerta mixed in with that? That's methylphenidate. Stimulants are insanely effective for ADHD. I think it's like 70 or 80% effectiveness compared to depression meds, which we prescribe all the time. When you account for placebo, are like 20% effective. So they're like insanely good in the psychiatric world. They're so good. And so I don't like when doctors just avoid stimulants altogether, because the alternatives, the Strateras and the Wellbutrins, are far less effective. So you're starting someone not on gold standard. But when you start on Adderall, that's kind of the strongest form. So anyway, to get back to the act a little bit, that's the problem, is they are trying to safeguard against opioid abuse, which then also we get scooped up into that whole mess because we're considered siblings. So with the Ryan-Heights Act, they didn't actually ever really define what like a special license would be in order to have a telemedicine practice. So then during COVID, they kind of dropped those rules. They because Ryan-Heights was in place since 2008. They didn't get around to doing it. So then COVID, they were like, okay, we're expanding telehealth. You don't have to have an in-person appointment to be able to prescribe any sort of controlled substance, schedule 4, 3, or 2. And then they kept extending the deadline. So it was going to expire, it looks like, in like February 2023. Then they pushed it out to 2024. And actually in that time, in 2023, they established the buprenorphine rule, which basically allows them to always prescribe medication in a telehealth only setting without the in-person visit for drugs that are helping you to, like, for people who are addicted to drugs, like addicted to opioids and stuff, to help them to wean off. So that's the point of buprenorphine. So they have made permanent amendments that are in place now, but in terms of the overall landscape of telemedicine and being able to provide over telehealth, they kept kicking the can down the road. So they did the temporary rulings in these number of rules. And what has happened now is that it's expiring. They've kicked the can down the road enough times. And so this has actually spanned multiple administrations, right? Like this started under Trump, This got kicked down the road multiple times under Biden. Biden proposed an amendment, and now it's back to Trump, and it's coming up again. Like they're having to decide on this definition that I guess got written under the Biden administration. But the Trump administration will ultimately decide if they want to enact it. And so this is kind of, we're not trying to make this political. This actually transcends politics in the sense that it's both sides of the aisle have contributed to the place that we're at today. And now what it'll ultimately come down to is if the current administration lets this new proposal happen, which got written before they were in office.
Which I am not confident in this administration to be on our side and help us out.
So it's like if you are an online telemedicine platform, like that's your whole thing, like Zoom Care. If you answer yes, then you can apply for a telemedicine platform registration for Schedule 2 through 4. If you are otherwise not entirely telehealth and exclusively telehealth, if you're a psychiatrist, hospice care, or something like that, then you can do Schedule 2 through 4. Otherwise, you can only do Schedule 3. So I don't hate that they are trying to get psychiatrists to be the ones that are prescribing Schedule 2 for us. But anyway, if you don't fall under like those categorizations, then you cannot prescribe Schedule 2 over telehealth, but you could do Schedule 3 or 4 if you apply for this particular license. So there's like 3 different types of licenses that you can apply for. So overall, don't know totally what to make of that section. And then there's this other part that is specifically for Schedule 2 substances. And again, I also don't totally know what to make of it. So the first proposed requirement would require that the clinician special registrant be physically located in the same state as the patient when issuing a special registration prescription for a Schedule 2 controlled substance.
That could either mean, and this is the thing, like typically to do therapy or psychiatry or mental health treatment, then you should be in the same state that you're providing care for. Now, what I'm curious about is that part about prescribing in the same state. Like, does that mean that the person prescribing it has to be in the same state because they are providing care in that state? Or does that mean like, hey, I went to go visit Tara in Seattle and my medication ran out. Can I get a prescription if I'm out of state? That's what I don't.
I wonder if it's the second one, because something that I have run into, because I think that there are already rules today about, I'm trying to think, I've done a lot of traveling and I've had to see doctors during travels because I've been out of state for a month or more. And I think I have seen psychiatrists for ADHD meds during COVID. I think in more recent years, they've not been allowed to see me when I'm in like Hawaii, but Hawaii has special rules. So when I've been in Hawaii, I've sometimes forgotten to pick up my meds. And then I'm like, hey, can you transfer it to like a CVS out in Hawaii? Well, it's never been successful because their rule specifically to the island is that it has to have been prescribed by a doctor located in Hawaii. But for some reason, they like really struggle to track this accurately. So then I get flagged as a drug dealer again. But the government like really is like worried about me. So I wonder, this sort of talking it through with you sounds like it might be similar to that Hawaii rule.
I was just looking up the impact of the DEA's proposed rule on special regulation for telemedicine. What I found is the telemedicine practitioners will still be able to legally prescribe the Schedule 2 through 5 controlled substances without an in-person visit, subject to restrictions, and they'll have additional authority to prescribe high-risk medications like Adderall, opioids, and stimulants. Again, how Adderall is, I guess it is higher risk, but the challenge is there will be increased regulatory burden and compliance requirements. So that means providers will have to apply for and maintain special regulation registrations and undergo DEA credentialing and comply with state-by-state telemedicine regulation rules. And that could vary from state to state. There's also uncertainty with the Trump administration. So if they modify or reject the rule, then providers may lose telemedicine prescribing flexibility.
This is another thing that kind of is confusing but feels concerning. So they say the second proposed requirement, specifically for Schedule 2s, would require that the average number of special registration prescriptions for Schedule II controlled substances constitute less than 50% of the total number of Schedule II prescriptions issued by the clinician's special registrant in their telemedicine and non-telemedicine practice in a calendar month. And so I think it's effectively putting a cap on how many telemedicine Schedule IIs. So if I'm understanding this right, if you're a psychiatrist and you are not full Zoom doc and you see some people in person and some people over the phone, then only 50% of the Schedule IIs that you prescribe could be telehealth. And so you'd either have to like jack up your in-person Schedule II prescribing or limit your telehealth Schedule II prescribing.
I can imagine a psychiatrist who primarily does telehealth, and by the way, by telehealth, we mean like could be psychiatrists that are just have a private practice,
right?
And there's nothing wrong with that. People do that because working in the healthcare system sucks. There are a bunch of hoops to jump through. And so if you just have a private practice and you're seeing a majority of your patients via Zoom and not through some weird platform, maybe because you don't have an office because you don't need one because most of what you do is just talking to people's medication management. And in that scenario, you might focus on ADHD because it's something you specialize in. So if you are a psychiatrist who just works from home with your private practice and sees people primarily for ADHD because it's your specialty, and 50% of your patient base cannot be ADHD medication prescriptions, then you're completely disrupting that person's business. And if it's putting a cap on their ability to prescribe, then that means you're going to have a lot more demand and not as many people that can fulfill it.
Yeah. And this is where it gets weird because of the 3 types of licenses. One of the types is telemedicine platform registration, which does authorize Schedule II, which means you're strictly telehealth. And so I think in that case, you could prescribe Schedule II continuously. And again, all this I'm saying, I don't totally understand this law.
Yeah.
But if you had the advanced telemedicine prescribing registration, which is where you're a psychiatrist who isn't exclusively online, it does allow you to do Schedule II, but then that's the one where I think they have the 50% quota. And so basically, like you could either go full telehealth, or if you have a couple patients who are in person, but the rest are online. Like, let's say it was a 25-75 split. And I have to imagine that's not an uncommon split because, let's face it, ADHDers struggle more to get to appointments on time and like make it out that like there's a substantial burden of actually going physically to the doctor versus like you can be 5 minutes late, realize that you're late, hop on the phone, turn on your camera or whatever. That, by the way, that's another requirement. You have to have audio and video, so you can't do camera off for before you prescribe for anybody. So you hop on, you turn on your camera like a good client. That's a much lower burden, and so I guess the doctors would either have to pick up more in-person patients to be able to like continue to prescribe, or they'd have to just go full telemedicine and basically inconvenience the folks who do come in, which, I think is also a burden on the flip side, because if you're dealing with someone who has comorbidities and you want to be able to track something like whether they're having significant weight gain, like if they're also taking an antidepressant, that's a really common side effect, or track their blood pressure, because that is something you're supposed to keep track of with stimulants, like things that require physical equipment in an office. The practitioner's option to keep their majority telehealth patients, they would have to just stop doing in person.
Yeah, that's crazy because like I can imagine a lot of, like you're saying, that there are a lot of health management scenarios in which going in person makes a lot of sense. For medication management, for ADHD medication specifically, I've mostly only ever, except for the one time, met my psychiatrist via teleconferencing software, right? Zoom and or the like. And the appointments are usually under 30 minutes. It's usually like 15,
Oh,
20
it's like
minutes.
10, yeah. Well, because that's what y'all have
Yeah.
to keep in mind too, if you aren't already intimately familiar with the system. They are not allowed to continuously prescribe something to us. And so I think the longest you're allowed to go in between appointments is 3 months, but I've even not been clear on that because I've had doctors tell me it's actually
Yeah.
one month or sometimes 2 months. I don't know.
So
So
the idea of like driving to a physical location to have a 10-minute conversation versus just like going on Zoom and talking through what's going on, like it's just
right, because that's how the conversation goes once you have settled on the correct med, and these are
yeah.
genetic lifelong conditions, right? And so they're like, hey, you still have ADHD? Yep. Does the med still work for you? Yep. Great. And that is the
Yeah.
extent of the conversation if you're not having major side effects or concerns or anything. And so I have to imagine for someone who is a psychiatrist who specializes in ADHD, probably 75% of their current session load is telehealth because it is a lot of those check-in appointments, and it's kind of annoying for both parties involved, right? But like my
Yeah.
doctor has at certain points been like, hey, would you want to drop down to someone with less specialization, because he's been around for decades. He's like one of the most well-respected people in the state of Washington in terms of ADHD management. But he's like, hey, like there haven't been changes in like a year. Do you want to like drop down to someone who's not, like to free up his schedule, right? Because it is like a burden on his schedule when he has like all this expertise, but he can't take on new clientele because he's having to do these like maintenance sessions with all of us. But I'm sure 75% of his sessions are in online. And so he would, under this
Yeah.
ruling, because he does work in a real office, he'd have to pick up a bunch more in-person people.
And so this has additional impacts for patients as well. I'm just kind of like looking at what some of those are, and some of the impacts are stricter identity verification and monitoring. So patients have to undergo an enhanced identity verification, including photo records and state level telemedicine tracking. And that's what you were saying a minute ago, where like you have to have audio and camera on. Pharmacies may flag or deny a prescription from out-of-state telehealth providers due to new verification. This one is I think is an alarming one, with potential barriers to Schedule II prescriptions. So some of these controlled substances, which are ADHD medications, may still require the same state provider presence on restrictions or restrictions on prescribing volume. And that's kind of what you're talking about, where it's like, how much can they prescribe? Which the impact of that is going to be people who are going to have, if prescribing volume is capped, people cannot get the medication.
Right.
And what we haven't talked about,
I've seen you. I've determined that you need a stimulant. However, I am already over my stimulant prescribing quota for the month. Good luck. Go see another doctor.
and what are you supposed to do? And the one we haven't talked about, which is pediatric patients may face additional requirements, including parental presence through telehealth visits. Now, that one doesn't sound like a big deal unless you imagine a pediatric patient might be like an under 18 patient, if that's how this is interpreted, right? So that could be like a teenager. By the time you get to teenage years, you might not want your parents to be present for your psychiatry visit because there might be other things to talk about that are personal to you as.
That is true. There are ADHD risk factors that are kind of exclusive to teens. So the risk of like teen pregnancy, substantially higher with ADHD. The use of alcohol and like the average age where you first start experimenting with alcohol is generally much lower than the average population. And so those are scenarios where, I think that that's probably a relevant part of your medical history when they're trying to determine A, if you have ADHD, and B, if the meds are helping. And that is certainly not the type of thing that you would want to have your parents in the room for.
Other uncertainty under the Trump administration is possible delays, modifications, or reversal. So because the rule was introduced just before Trump took office, the administration could delay or reject it. And that leaves it uncertain about the future of telemedicine. If implemented, the rule would be the first major expansion of telemedicine prescribing since the Ryan-Hay Act of 2008. And it balances access with safeguards against those controlled substances. But the requirements could burden providers, pharmacies, and patients and limit access to these essential medications?
So we want to make it as simple as possible for you to be civically engaged and have your voice heard. And so what we're going to do, we have a website for you, and it's got a whole bunch of statistics about why it's a bad thing to limit access to ADHD medication, not just for us, but for society as a whole. But we want you to understand the repercussions. And so what you're going to do is you're going to copy one statistic. Just one. We have a whole bunch here for you, but just pick one, keep it simple. Step 2 is to add one more sentence in your own words. And we're doing this because we don't want the sentences, or we don't want the submissions to be flagged as being from like a bot or something. Like if we all copy and paste in the same thing, I don't know if the government would assume that that's like from a bot and then throw them out. So just like add one extra blurb in your own words. Then step 3, we're going to link you to the place where you add your comment. And so what that might look like is if you pick the one about car crashes, about how we're significantly more likely to get in a car crash if we are unmedicated, just copy and paste the stat that we've given you. Step 2 is say, this makes me fearful for the safety of my family and friends. That's it. It can be short and sweet, just one little thing in your own words. And then step 3, post it on the government website, because they do have to review every single comment that we post. And so what we want to do is flood them with accurate information for how this would not only impact us, because I don't think that necessarily everybody in the legal system is thinking about ADHDers, but how it would impact society as a whole, because this thing would have a really negative implication for society at large.
Do you want to talk about some more of the, just to kind of make it relatable, like what some of those other risks are?
So basically, when ADHDers in aggregate don't have their access to their medications, it's not good for society. It impacts more than just us. And so, of course, we could talk at length about the benefits of ADHD meds to ADHDers, but we want to actually talk about the impact that it has on the people around us too. And so it's in the best interest, not just of us, but of anyone who exists in a society with people with ADHD to get us our meds.
It's just, I'm mad about, like, I don't want people to abuse medication. I don't want people to die from it. Like, there is risk, obviously, but I'm just mad because it has so many positive benefits, effective, clinically documented research, effective benefits for people.
Yeah. Well, it's like, I also don't want to get hit by a car driven by someone who has unmedicated ADHD. Like, right. Oh my God, like make it easy enough for them to get their prescription and continue to get medication. Like, don't gate it behind in-person visits, because chances are we ain't going to show up, and we're going to get dropped and not be able to access meds. And then it poses a risk to society.
Yep.
And so when you're writing your comments, emphasize that.
Yes.
The lawmakers and their families are equally at risk.
Cool. Hopefully this was enlightening. Hopefully this was educating. I know I learned I learned something as well. So this is an unfortunate situation for a lot of reasons, but this is something I think people can take action on. So hopefully we can get involved and make an impact here so that people can continue to get the medication that they need, the life-saving medication that they need.
Yeah, it is not too late to have your voice be heard. Like, we can try to directly influence the outcome here. So we've provided links. We've provided you with resources. We've tried to make it as easy as possible. Please just drop a comment. Just 2 sentences, one with a statistic and then your own little extra blurb, 2 sentences. That's all it takes. And if we can force the lawmakers to be confronted with these statistics, because they have to read all of your comments. So bombard them with statistics, bombard them with facts, make them confront this reality over and over, then they will think about their own families too, hopefully, and their loved ones, and they will hopefully not want more people who are addicted to substances and less good at driving and more likely to commit crimes, and people who are spreading STDs.
Yeah, right.
We are ticking time bombs.
Unfortunately so. But there's something we can do about it, right? Like, there's something we could take our medication and we can get involved. So
yeah, absolutely.
This was a fun one because I got to be like ranty and rambly a little bit.
Yeah. Cool. Well, thank you. See ya.